So welcome back to Endoscopy Essentials, IBD Essentials specifically, and welcome back, Raf Bisschops from Leuven.
Thank you, Thomas.
So we have brought successfully the difficult Crohn's topic behind us. Now it's seemingly getting easier with the endoscopic classifications of ulcerative colitis. Enlighten us, please.
Yes, so we'll address two, and obviously the most common one is the Mayo score. I think it's a very simple score, especially the endoscopic part of it. So we come back to the other parts of the score, but the Mayo Activity Index and the endoscopic component is quite easy because it's just 4 scores. It can be normal or healed mucosa, mild disease with erythema, faded vascular pattern, and some mild friability. And the main difference, determining factor between 1 and 2 is whether there are erosions or not. So if you can really see defects, so once you have that, then it becomes a score of 2. And then the very severe disease is when it's very friable, spontaneous bleeding, and deep ulcers.
So again, we have nothing, no ulcers, ulcers, and very ugly.
Yes, exactly.
Okay.
It's a little bit simple.
It's seemingly easy, but the inter-observer, again, might be quite substantial.
We come back to that in a minute, especially in the lower end of the disease spectrum. I think a Mayo 3 is easy to assess. And it's also very important to emphasize that these scores are usually made for the rectal sigmoidoscopies, because that's the thing we use to survey and to follow up therapy in these patients. When you always score the most severe part, right? So let's have a look. So this is an example of score 0. So, and you can already immediately see that maybe the one on the left side is, you might see a little bit of erythema. So some people might call this already Mayo 1. Some may call this, say, okay, this is just more pseudopolyps that are a little bit reddish. So the easy one is on the left here, right? So when everything is normal, but I'm sure that on the one on the right, you can have some discussions.
And it says inactive disease, which is a little bit vague, but that's not mucosal healing then.
Well, it is. So the definition of mucosal healing is also something that is still open for this discussion. But this is actually Mayo 0 and Mayo 1 is called mucosal healing, right? And although in Mayo 1 you still have inflammation, right? So this is a typical Mayo 1 score where you have the erythema in the middle. There is no bleeding in this case, but especially the vascular pattern is gone. So this really helps. And the most important factor is obviously that there is no epithelial defect there. And that's the discrimination between Mayo 1 and Mayo 2. But again, the Mayo 2 can also be a little bit of a spectrum, right? Because on the left side, you can see a Mayo 2 that is, you have some erosions in the middle, right? So here, there's an erosion, there's an erosion. So that drives you to say it's Mayo 2, but maybe in fact it's not so much different from this Mayo 1 where there's no erosions, right? But anyway, if you see these, it means you are in a Mayo 2 phase. But the same score could apply to this, where you already have marked friability without a deep ulcer. So this is not yet a Mayo 3. So again, there's a bit of a range between the same score, as you can see.
Range.
Yes, exactly.
And the left-sided picture looks, the right-sided picture, from the slides perspective, looks more similar to the Mayo 1. It's just the difference
with the erosions. Exactly.
Okay.
Yeah, but you need to come up with a definition, and that's what it is in the end. Also, because having erosions means that probably you have more disease that is more disruptive, where you have disruption of cells and creation of, or the beginning of ulcers. And then the easy part is this, obviously, when you have the deep ulcers with the pus on top and spontaneous bleeding, like the patients also complain a lot of rectal blood loss. So I think this is quite easy, but again, the difference with that Mayo 2 here, there's a bit of overlap maybe, and that also explains, I think, the inter-observer or observer variability for these scores. Although it's only a 4 ranked or 4 grade score, which is obviously easier to apply. So that's the endoscopic part. The problem with the Mayo score is also there's another part to it, right? So
a mixture with the clinical.
A mixture with the clinical. So that's usually combined also in studies. Some of it is basically asked to the patient, so how many stools are there, and refer to what is normal for the patient, which is also sometimes already difficult because you can wonder if a patient is happy if he goes 3 times a day to the toilet. That could be normal for that. And then depending whether it's 1 or 2 or 3 or 4 or more than 4 stools per day, more than normal, then it gets another 1, 2 or 3 points. The rectal bleeding, I think it's not so difficult to assess whether it's more or less than 50% of the stools or continuously there. And then the last part, I think, is the most difficult one and most cumbersome one for inter-observer variability. That's the physician's assessment of severity, which is probably driven by, well, what the patient looks like, already what is mentioned in stool frequency and blood loss, and probably also lab tests and the presence of fever and so on. So, but, well, how that affects the score is obviously maybe troublesome.
Well, as endoscopists, we would feel much better with a simple endoscopic score, or endoscopic score, how simple it ever is, but yeah.
But the problem, obviously, with the endoscopic score is if you have one deep ulcer, that's also Mayo 3. And that's probably why these clinical parameters were also included in this study, because probably the blood loss will be limited for that, and that kind of corrects a little bit for the simplicity of the Mayo endoscopic score, right?
Is it the endoscopist task? No, you do the Mayo part, and the rest is done by the IVD outpatient.
Yes,
clinic.
yeah.
Oh, okay.
Unless it's in a trial, then you do everything, right? Because of the simplicity, and actually what is also interesting to mention is that the Mayo score was never objectively validated. So it's used everywhere and everybody knows it. But the only validated score, and nicely developed score, is the UCIS, is the UC Index of Severity. From Simon Travis, did a lot of work there, and it's a bit more granular. So it kind of takes into consideration whether disease can be patchy, especially in what concerning the vascular pattern that can be visible, totally not visible, or patchy obliteration. And also the bleeding is graded, so you can have a small mucosal bleeding if you have some coagulated blood, or it can already be blood in the lumen when you come, or really frank bleeding that could be severe. And also there's a distinction between the erosions, whether it's small erosions, which are smaller than 5 millimeters, and typically these yellow color, and then superficial ulcers, which are more than 5 millimeters, and then the deep ulcers like the ones that I showed you are excavated. And again, it's scored for the most affected segment for sigmoidoscopy.
And that's a merely endoscopic score?
Yes, yeah, there's no clinical components to this, Obviously, one of the issues with these scores is always it's the rectal sigmoid, but we also do obviously total colonoscopies in these patients. And a little bit like with the Crohn's disease, we talked about the cutoff of 15 and it can go to 60. It's a little bit the same here. If you have one ulcer in the rectum, it would be Mayo 3. But obviously, you would assume there's a difference if a patient has a pancolitis Mayo 3 or just a rectitis Mayo 3.
With 100 ulcers.
Yes, exactly. And that is a bit reflected in the modified Mayo endoscopic subscore, where this assessment is then made again for the 5 parts of the colon. So you have the ascending part, transverse, left, sigmoid, and rectum. And in fact, that is the case. So if you look here, this study from our group, where you can see that if the patient has a higher total score, this also reflects in a higher fecal calprotectin, and that the patients have more severe symptoms. And that kind of makes sense. And also, again, the score will be more prone to change if you give the patient therapy, right? So because now if you have, like, let's say you have a left-sided colitis before your therapy, which is Mayo 3 from 0 to 60 centimeters, and that decreases to 5 centimeters with one ulcer, it would still be a Mayo 3. So for studies, this is also a bit cumbersome to have a score that is like that, because on paper there would be no change for that patient, while the patient's probably doing much better. Okay, so let's look at a couple of examples here from a quiz that we organized. So again, why do we call this Mayo 2? Is, remember, the minute you have erosions, then you're already at Mayo 2, right? Again, you can use here the virtual comandoscopy modes where they're more visible. So, but then again, the UCS reflects a little bit more the severity or the lesser severity of this particular patient. Because for Mayo, this is Mayo 2, so second level. But you can see that the vascularity is not totally obscured. So for vascular score, it's only 1. There is no bleeding, so there's a 0. And when you look at the grading of the erosions, that could go from 1 to 3, it's only 1. So this is Mayo 2, but the UCS is only 2. Right, so therefore this score is a little bit more granular. Again, this will be shown here again. So again, this is also Mayo 2. Again, nice illustration of the range of the score when we talk about the Mayo endoscopic subscore. But in terms of the UCS, this is not correct. This should be V2 because it's completely obliterated. And there are more erosions here, you can see. But they're probably not bigger than 5 millimeters, so this is 1. And there are small intermucosal bleedings, like here, this patchy blood here. So again, this score has V2, bleeding 1, and UCS 1. So this is a score of 4, right? So again, for the same Mayo 2, you have a better differentiation. And then we go to the frank bleeding, and maybe there the difference is not so important. You can see stricture, you can see the spontaneous bleeding. So it's clearly a Mayo 3, and you have a maximum score of 8 on the UCS here. All the features are there. So here it's very easy, right, to assess the score.
It's at the ugly end, as we said.
Exactly. So, and here the inter-observer agreement is very high. Yes. So there's no doubt here. Again, here, where there's a good correlation, you have some mild erythema. So this is a very mild disease. You can see a normal vascular pattern here, but if you move down, you have the hyperemia. So for the distal 5 centimeters, this is still a Mayo 1, and the UCS is not 2, but 1, because you can still see the vascular pattern. But again, the extent of the disease is not so well reflected. This is not a total rectitis, it's just the last 5 centimeters where there is still some residual inflammation, and this is currently not really reflected in these scores.
What would you do if you find this during a screening colonoscopy and the patient doesn't report any symptoms?
I probably take a biopsy here. Yeah. Yep. You might probably miss it on the way in. So if the patient has diarrhea, we always do the IBD biopsy protocol. So that means you take 2 biopsies in every segment of the colon and the ileum. But you're very likely to miss that, I think, if it's just 5 centimeters and the distal rectitis. But then I would definitely take biopsies here.
Because if this is a ulcerative colitis patient, then he is under therapy. It's a different thing. But and if the biopsy comes back like mild inflammation, you would then, when the patient is asymptomatic?
I would not start therapy. This could also be a prolapse even, this finding. And so it's very this lower end. Yeah. Here we know the patient had the ulcerative colitis, so then we can use the score. I would then also not use immediately a Mayo score if I'm not sure if the patient has ulcerative colitis.
Then he has the label forever.
Exactly. Yeah. Okay. So here I have another nice example, and it really nicely shows these examples what the range is. Again, the same Mayo 2, we have some inflammatory pseudopolyps here now, but in terms of vascular pattern, you can see that it's visible in some parts, so it's patchy obliterated, not everywhere. And then we have the erosions here, which are less than 5 millimeters, that are really small here. So these are not
What about
ulcers.
Those eroded polyps, pseudopolyps?
Yeah, they're not accounted for. So we just mentioned them as inflammatory pseudopolyps. Also, I think you should not get overexcited resecting them. So it's a typical appearance here. They have a red stalk, very inflamed stalk, and typical the fibrin cap on top. So, I mean...
And that has nothing to do with surveillance, right? So these are almost never malignant.
No, these are not, but it is a risk factor. So there's been some discussion on pseudopolyps where you should take it into consideration, but I think logically, I mean, it's a sign of bad inflammation and regeneration. So if you have many of these, I think I would take this in consideration for 2 reasons. First of all, I mean, it's a sign that the inflammation was bad. And second, the surveillance itself may also be more challenging. So that's why we take this into consideration for defining the surveillance interval. Okay. And here again, we have the Mayo 3, where spontaneous bleeding, and together with, but again, it's a little bit more differentiated in the UCS, where the bleeding is not so frank, so you get only a score of 2, right? and the erosions here are actually also not so pronounced. It's not, so the Mayo 3 can come with deep ulcerations, as you can see. And in this case, it's a Mayo 3 because of the spontaneous bleeding that you have. But in the USCS, the score is only 6 out of 8. So there you discriminate. It's more granular.
Tell me about spontaneous bleeding. Is it bleeding in front of you when you do not have passed yet?
That's a very important point. So during the development of the UCS, it was really mentioned that it should be on introduction. So you assess the bleeding before you pass. Or before you start.
The rest is vulnerability, and it doesn't count.
Exactly. Especially if you have some difficulties passing the sigmoid. So it's before you pass. If you can see the blood coming to you. Or if it's there like this. And then we have this special case. So I included this because this really nicely, clearly shows the distinction between the Mayo score and the UCS, and where probably the advantages of a more granular score, because there's one erosion we just passed it. It's going to come. It's even a little bit better visible with it's over there, right? And because of the erosion that you see, you are forced to call this Mayo 2, right? But obviously, this is not the same Mayo 2 that we saw before with the bleeding and retinas all over the place. But you can see there's still some inflammation, and there is, per definition, an erosion here. There's no doubt about it. And this is also where probably if you do like inter-observer studies that many people would say, I don't see anything. It's only after longer observation that you see this one erosion, and then per definition, you should call this a Mayo 2. But again, there the UCS helps to discriminate better because obviously the vascular pattern is visible. There's no bleeding, and this is a small erosion, so you only get 1 point for the UCS, whereas it's already the third level in the 4-grade scale of the Mayo score. And this is obviously the problem also. When are we going to call something healing? When can we assess mucosal healing? Is this mucosal healing?
If it's the only erosion in the entire colon, which was significantly inflamed?
Yeah, but according to the studies, this would be Mayo 2, right? And the question is indeed, does this really matter? And there's more evidence appearing that maybe it is, right? Especially, again, in the past, we didn't have many options, and we would accept this definitely as a good outcome. But the question is also, at some point, so you either want to target a certain target, right? So maybe you want to have either mucosal healing, histological remission. That's something that is still a matter of debate, whether we need that. Seems that histological remission may be even better than pure mucosal healing. And then what is mucosal healing? How do we define that with the scores we have? So that is important, and also the question is, once you reach that point, at some point you might want to consider stopping therapy, the so-called exit strategy. And the question is then, how deep does your remission need to be before you consider doing that in patients? Especially in the United Kingdom, this is something where they really consider doing this if patients are a long time on biologicals. So this brings us to the point of what is mucosal healing, the old definition is Mayo endoscopic score less or equal to 1. So you can have still inflamed mucosa, and the advantage of it is very...
Which is relative healing, maybe.
Yeah, maybe. With the new insights it is. But there's already... The reason is because it already, if you have that, it reduces the rate of colectomies. So that's clear in studies. But as we clearly illustrated in the examples, it's only a 4-grade scale, so it's kind of rudimentary, and even like the Mayo 2 we saw in the last example may not be that bad, right? So the UCS is a little bit more quantitative, more complex in a day-to-day endoscopy practice, but it's probably also more responsive to change.
But it's also interesting how mucosal healing is defined. So it's not complete mucosal healing. And I think you mentioned it before that we are going more and more into complete mucosal healing, complete histological healing. So there are different challenges, because now we have talked about obvious inflammation nobody would doubt. You can maybe start discussing this one erosion you find, which you, by the way, sometimes find in patients where you don't know, in the sigmoid colon, and you don't know what to do with it. Biopsy comes out non-specific, so same problem. But these are new challenges, and I think we'll touch upon them in our next episode.
Yes, we'll do.
Thank you.